Thanks very much, Paul, and thank you very much, everybody, for welcoming me here today. It's fantastic to be able to talk to you and address you, and hopefully I'll get the chance to talk to you later. Some of you, and many of you, will recognize the photograph on the left, which is where the sun is setting on Galway Bay. And I'm not going to start singing, but I've just recently started in Galway, and I had been in London before that, but I grew up in Dublin, not too far from here, and did a lot of my studies here, so it's also wonderful to be back in Dublin. But in watching the Ryder Cup yesterday, many of you will know that it was kind of a washout yesterday with all the rain. And it just brought memories back to me of London, where in London everybody gives out about the rain and how terrible it is. And I used to think it's fantastic over here, you get so much sun. It's nothing like the rain compared to Dublin. But it's only since I've gone to Galway that I've realised there's nowhere in the world like the rain in Galway. So in talking to Mike Glynn and to Aisling about what I might present on today, I was keen to present something on genetics of epilepsy. And Mike said maybe we might extend it to talking about the family, which got me thinking. Of course, when we think of genetics, we think of things that do run in the family, but of course not every thing that runs in the family necessarily has a genetic basis, and not everything that's genetic necessarily runs in the family. That's a theme we'll come back to a little bit later. One of the things I've been struck by throughout my training and with my own clinics now is that people who have epilepsy and attend an epilepsy clinic are more likely to have an accompanying relative with them than people who attend a general neurology clinic, which wasn't something I'd really thought about before until thinking about giving this talk. And I think once a diagnosis of epilepsy is made, there's kind of a ripple effect immediately. If somebody in the family has epilepsy, certainly the immediate family know about it, but oftentimes the extended family know about it. One of the first questions we ask, or I ask, is do other members of the family have epilepsy? And people will know if cousins or second cousins or granddaunts, whether they be in another country or not, have had epilepsy, which is different from other neurological conditions, say like migraine, where people mightn't necessarily know, but everybody's familiar with migraine, or potentially serious medical conditions like asthma, where it's not always known if another family member has asthma or not. I think that just gives an indication of how major a diagnosis of epilepsy is among a patient, for a patient, and also for a family. I think that ripple effect then extends into the local community, and by the local community I would include people, work colleagues and friends, and then to the wider society, where there's healthcare provision, so doctors and epilepsy nurse specialists, and all the different people and government agencies who are trying to make policies for people with epilepsy and provide epilepsy services. But one thing that comes across really is that patients and their families tend to go through the experience together rather than being very different or being very separate. So in terms of trying to understand, for me at least, what is the link between family and patients and what do they go through together, I've tried to conceptualize it in maybe 4 ways. And that's the cognitive, the psychological, the social, and the stigma that can be associated with epilepsy at times. There are different types of epilepsy, and as you'll all be aware, and some types of epilepsy, if we say temporal lobe epilepsy, which would be the commonest type of focal epilepsy, often has a mesial temporal or a mesial temporal onset, and that can be around the area of the hippocampus, which is very important for memory. And one of the things that many people with epilepsy, and maybe not just with temporal lobe epilepsy, say to us when they come to clinic is that they're having difficulties with their memory. And that is something, the memory things are very difficult to treat. But the ongoing seizure activity, which can worsen memory, sometimes can be more of a spur to try and treat that better. But memory impairment has, of course, very significant effects for people in their life, in making day-to-day arrangements, in their work, and also then by corollary for their family. People who have, with epilepsy, who maybe have a lot of seizures, can find it very difficult to concentrate. Certainly during the time of a seizure, but oftentimes in the postictal period after a seizure, it can be particularly difficult to concentrate, to attend to things, to give your full attention to everything. Then there's at least 20 anti-epileptic drugs that are available nowadays, and some of them have general problems with making it difficult to concentrate. They can be associated with drowsiness. Sometimes these are predictable, sometimes they're dose-related, oftentimes they're not dose-related or predictable. And of course everybody's different, and sometimes the anti-epileptic drugs interact with each other. And then there's the seizure burden, which again I think comes back to my point about sometimes the more seizures you have, or that a patient with epilepsy has, sometimes the greater problems that can have on people's memory. So all of these things, the cognitive effects, if they affect the person, will affect the family, will affect their relationship with the family. I think one of the most important aspects for people with epilepsy when they come back to clinic is to explore the psychological effects, the negative psychological effects that this may be having on them. Many patients with epilepsy, certainly when the diagnosis is made, understandably is associated with anxiety. And ongoing seizure activity can also understandably give rise to a lot of anxiety. And in particular, it's the unpredictable nature of the seizure, when a seizure is going to occur, that must be very hard for people with epilepsy to deal with. And of course, if there's problems with memory or problems with cognition, or people with epilepsy can't do everything that they want to do, that can cause problems with mood, particularly low mood, and sometimes depression. Epilepsy is often a lifelong condition, and in people who have epilepsy where it's been difficult to control their seizures, this can affect their self-esteem, which again can have quite serious knock-on effects, but it's something that may be overlooked sometimes in a busy clinic. I think one of the points that I often try to make is that epilepsy is a part of somebody's life, but not the major feature of their life. I realize myself that's an easy thing for me to say, but I think that oftentimes epilepsy naturally becomes part of people's identity. Whatever medical condition we have becomes part of our identity, and oftentimes that's an unwanted part of our identity, and something that people with epilepsy have to get their head around. And all of these things can result in a loss of independence that people with epilepsy would otherwise have had and would aspire to. And because the relationship between patients and their immediate family is so strong, I think a lot of these factors that I've listed here are also impacting on the family members. I had a school friend who I lost touch with somewhat, and got back in touch with again. His second child had quite bad epilepsy in so far as she was having an awful lot of seizures, and I visited him a few times since then, but it really brought home the anxiety that he and his wife experience in how their daughter is going to be brought up. And I think when relatives come to the clinic with people with epilepsy, of course they want their son or their daughter or their wife or their husband or their sibling to be able to explain what's happening to them. But they also are anxious. They're anxious for their child. And it can affect their mood. And it can affect their identity, maybe their identity as a family, where sometimes in communities where epilepsy is not as well understood as it might be. Many of these things then will affect people's vocation, affect their career choice. Sometimes it may be difficult for people with epilepsy to go into the career that they would want to follow. They may miss days with work, and that may result in a loss of financial independence. They may not get as well paid as they should be getting paid for the attributes that they bring to their career. I think financial independence is almost like a human right. It's something we all strive for. And that's a major effect, I think, on people's psyche. And who's going to pick up that if people don't have financial independence? Oftentimes it's family members, so that puts sometimes a financial strain on family members as well. And this is something that doesn't always come up in clinics, but can be a very significant underlying issue in the relationship between a family member and somebody with epilepsy. Of course, it can affect friendships. Again, not everybody understands what epilepsy is. This has been a problem down throughout the ages, and it continues to this day. This is something I'll come back to a little bit later. And I think one of the sometimes even more devastating than the onset of seizures is the effect of seizures in terms of the driving regulations, particularly in this country, where one must be seizure-free for a year before being able to drive if the seizures are occurring during the day. And once you say that, sometimes people immediately want a second opinion about things. This is a major effect, understandably, for people with epilepsy, with ongoing seizures, on their life, on their independence, something that maybe the rest of adults take for granted. And I'd see couples where both are working, and then one is diagnosed with epilepsy, and maybe they work 30 or 40 miles apart, and they have to make massive rearrangements to their life, to their family structure, to be able to drive people just to work and to continue what they used to do in their normal life. So the diagnosis of epilepsy in a patient also can have quite dramatic effects on every other member of or other close members of the family. And then there's the issue of stigma, which I think even to this day people with epilepsy have to cope with. I think there's three ways of considering stigmas. I think there's institutionalized, interpersonal, and internalized. I think the first two are quite obvious. I think with time, and I think in this society, there is less institutionalized stigma towards epilepsy, but it still exists. And by that I mean sometimes it can be difficult for patients with epilepsy to receive insurance policies for certain things. There is the stigma that people with epilepsy may encounter among their friends. And by stigma, I mean that there is a loss of status because of a negative perception that somebody has about an attribute that somebody else has. And the specific attribute is epilepsy. And again, because people don't understand it, and because they might be understandably afraid of it, it can be difficult for people with epilepsy to have the friendship with somebody that they might otherwise have had, or it puts it on a different plane. And then I think there's also internalized stigma. I think people with epilepsy, as with other disorders or other neurological conditions or whatever the medical condition that they have, may give rise to negative feelings and negative beliefs and negative thought processes and negative constructs of their place in society, their place in the family. So they can feel that the diagnosis of epilepsy is holding them back, which can also be a form of stigma. I think one of the things I've alluded to already is the burden of seizures. Again, if a person with epilepsy is having a lot of seizures, one of the big things in people with epilepsy is safety. People who have particularly generalized tonic-clonic seizures can injure themselves severely in an epileptic attack. And we give advice, of course, in clinic, but it's family members who have to really, I suppose, take care of patients, particularly when they're having seizures and they're around. And if people are having an awful lot of seizures, say a number of seizures per day, then there can be quite a burden on family members as well, obviously, as on the patient with epilepsy. Something I think we don't consider a lot is a burden of normality. So if we take people who maybe were having seizures that were initially uncontrolled, and then they go on an appropriate anti-epileptic drug and they become seizure-free, but had uncontrolled seizures for a while, there has to be a readjustment to the new life without seizures. And that takes a different length of time for everybody. And what's interesting is that length of time, that period of time, can be different for relatives of that patient as opposed to the patient themselves. So if people become seizure-free after successful epilepsy surgery, where epilepsy has been quite a major part of their life up until then, and now they've had the epilepsy surgery, and thankfully they've become seizure-free, and relatives and friends and sometimes doctors say, well, you're seizure-free, it's fantastic, you're doing great. But they have lost something that they had to get around, was their seizures, and became part of their construct of life, really. And that can set up tensions within a family where there's a different time period of adjustment. And I think that comes down to something that we're beginning to recognize belatedly as doctors, is this standpoint theory. What standpoint do people come at for how they cope with a certain life event? So as doctors, because we see a lot of conditions, I think we think we're experts. We think that because of the experience in meeting and talking to people about their experiences with certain things, that we can somehow say, well, this is my experience with people I think are in a similar boat to you. But really nobody's in the same boat. Everybody's different. We all have our own philosophies on life. And I think that's something as doctors and as healthcare providers we have to be more cognizant of. And that is, what standpoint do people come from? What level of toxicity might they be willing to put up with anti-epileptic medications to have a reduction in seizure freedom, or to reduction in seizure occurrence? And that's different from everybody. And I think I worked with another colleague in London, a professor of epilepsy, and his motto, one of his mottos, we had a few, but one of them was, the patient is always right. And I think that's certainly true. But I think oftentimes the family is also right. And that's something I think is, when I was thinking about giving this talk, is something that just came to mind a little bit more that I mightn't have realized up until now. So how do we improve all of these challenges that come from patients with epilepsy and their relationship with their family? And I think the main way is through education. It's education in the epilepsy clinic, it's education through epilepsy nurse specialists, and in particular it's education through days like this, organized by Brainwave, where people come from different backgrounds and can share their experiences, and we can educate each other as to what's going on, and hopefully educate the wider community and influence societal policies in how we cope with epilepsy and develop strategies for that. I think one of the main things is that we all develop an awareness of the challenges, all of the challenges that come for people with epilepsy. As a doctor, I suppose the first thing is that we do no harm. It's one of the main things that's kind of drilled into us from medical student days. So we take care to make sure we're giving the right anti-epileptic drug at the right dose, that we're monitoring people not getting medical side effects, or that we look after them if they do. But there's so many other aspects to it that we've touched on now, and I think that's something as doctors and as family members that we have to be cognizant of for people with epilepsy. And now I want to talk a little bit about the genetics of epilepsy. It's sometimes a question that is raised. Another member of my family has epilepsy. I have epilepsy. What is the risk my children will get epilepsy? Now, that can be a difficult question to answer, and I don't think I'm able to answer that today, but a genetic link with epilepsy has been known since at least 450 BC. So this statement is ascribed to Hippocrates from at least 450 BC. But it's only in recent times that we have begun to scratch the surface of our understanding of what the genetic contribution to epilepsy is. And some epilepsies have a greater genetic contribution to them than others. Most epilepsies are acquired. So in a general sense, I would say most or all epilepsies do have a genetic contribution to them at some stage in the process. But I would say that for most epilepsies, although JP may disagree with me, that genetic contribution is not so large. But even if we take people who, say a person who has a stroke and then a year later may suffer a seizure, that another person who seems to suffer a similar stroke and has a similar comorbidities to that patient doesn't suffer epilepsy. So what happens from the initial, as we say, insult to the central nervous system, say in this case a stroke, and then a year later something is going on for a year, some maybe scar tissue is forming around the area where the stroke occurred and is giving rise to an area where seizures may occur, and then seizures do occur a year later. But why does one person get seizures and not the other person get seizures? So undoubtedly there is a genetic contribution even in that case where there's quite an obvious insult to the brain in the first instance, namely a stroke. So I mentioned that epilepsy has been known about since ancient times, but I think it's what proof do we have that epilepsy has a genetic basis? And I think the origins of this proof began with William Lennox, who's also given his name to a particular epilepsy syndrome called Lennox-Gastaut syndrome. But he was the first to perform twin studies. And in fact, this is a photograph of twins that he looked after in France. They're called Catherine and Constance, who both developed seizures at 6 years of age. Now, interestingly, and this is their EEGs, and the EEG looks the same. There's an epileptic discharge on it. And this got him thinking as to, is there a genetic link in these twins who have epilepsy? I think a lot of the important work on twin studies has been performed by Professor Berkovic in Melbourne in Australia. And his idea, and the idea with all twin studies really in trying to form see if there's a genetic link, is to compare identical twins with non-identical twins. So identical twins share the same exactly the same for all intents and purposes, the same genetic makeup, whereas non-identical twins are siblings, they're brothers and sisters, they happen to be born at the same time, but they're not as identical genetically as identical twins. Now, both identical twins and non-identical twins, assuming they're not separated at birth, will share the same environment as well, so that has to be taken into account. But if we think that genetic has, or that epilepsy has a genetic basis, then our theory would be that people who are identical genetically would be more likely to have both of them to have epilepsy than than non-identical twins. So we're taking the environment covariate out of the equation. And indeed it is true that that identical twins would have a greater likelihood of suffering both of them suffering epilepsy than non-identical twins. But the really interesting thing is that certain epilepsies are much more genetic, seem to have a much greater genetic contribution than others. And they, in a general sense, would be what we term the primary generalized epilepsies. Oftentimes epilepsies that begin in childhood, like childhood absence epilepsies, or adolescent epilepsies like juvenile myotonic epilepsy. Whereas epilepsies like temporal lobe epilepsy may have less genetic component. I just want to speak very broadly about the inheritance of epilepsy. So again, to maybe put this into historical perspective, this is a poor picture of Gregor Mendel. And really, through his experiments with peas, he was the first to at least write about the different possible modes of transmission of any genetic condition. He did not look at epilepsy. So in a broad sense, conditions that run in families and have a genetic basis can be either autosomal dominant or autosomal recessive or X-linked. And so in me, I have 2 copies of every chromosome and 2 copies of every gene. I've received one from my mother and one from my father. If I carry a condition that I could pass down to my children and it has autosomal dominant transmission, then I just have to have one faulty copy. So I could have one normal copy and one faulty copy. And if I pass down the faulty copy, so that therefore there was a 50-50 chance, say, that my children would inherit the faulty copy, but a 50-50 chance that they will inherit the good copy. Then there are other conditions where it needs the two genes to be faulty for the condition to be acquired. So I have received one copy from my father of a certain gene and one copy from my mother. Neither of them has a particular condition. because it needs both of the genes to be abnormal. But if I receive the abnormal one from my father and I'm unlucky enough to receive the abnormal one from my mother, then I may inherit the condition. So something like cystic fibrosis would be inherited in that manner. I won't talk too much about X-linked inheritance, so that would be less common. And does anybody recognize this picture or these two characters? This is Watson. Say it again. Watson and Crick, exactly, who discovered the blueprint, I suppose, of genetics, which is DNA, in 1953. But after spending a little while explaining so-called Mendelian inheritance, so called after Gregor Mendel, I think that, and this would be a personal opinion, but I think that most epilepsies are not so straightforward. The genetic contribution to most epilepsies is not so straightforward. I think there is it has an oligogenic inheritance. So I think there's oftentimes in families, well, sometimes in families, say, who have epilepsy, there may be one gene that causes, and you either have the gene or you don't, or you have two copies and you get it or you don't get it. But I think for many people, even if a cousin has epilepsy, it may be that there is 20 genes, or 20 genes, or 20 different areas within our genetic makeup that may, if they come together, say in a combination of 5 or 6 or 10 or whatever that might be, increase your risk of developing epilepsy. Now, this is a much harder thing to discover, I think, to discover these genetic variants than to discover the genetic abnormality in people who have a clear family history of epilepsy where it's going down through generations. So with these arrows, what I mean to say is you might have a general risk you might have one gene that maybe predisposes you for epilepsy, but you don't have any of the other 19, say, genes that might predispose you, so you never get epilepsy and you never know you had a slightly increased risk compared to the normal population. But say then there's another gene that you also have, you have another genetic risk factor for it, maybe you'll develop epilepsy, and perhaps if you have a third risk factor that will dictate what type of epilepsy you get. That's speculative. So what have we learned from genetics? I suppose the first thing, what is epilepsy? And it's an abnormal firing of a set of cerebral neurons. And how do neurons fire? Well, there's a change in polarity down through the nerve. So all our nerves have some positive and some negative electrical activity, if you like, on the inside and the outside. And there is gates along each of the nerves. And if this gate is opened in normal circumstances, then there is an inflow of charge, which then spreads down through the nerve and joins with other nerves and joins with other nerves and other nerves, and there's billions of connections within the brain. And if they achieve a certain threshold, or if there's an abnormal circuit within the brain, then we might have an epileptic seizure. But this is also a normal process. If I want to move my left hand, something has originated in the right side of my brain to initiate that process. So it's a normal thing. But what we found with certain people, well, I say we in a general sense because I haven't been fortunate enough to be part of any group that has discovered some of the genes, but what has been found is that there is sometimes abnormalities within these gates. So some people have more of a tendency, the nerves are more hyper-excitable, if you like, for developing an epilepsy. There has been an exponential growth in genetics in general, but also including in studying genetics of epilepsy. And this has really come about since Watson and Crick described that DNA is the underlying blueprint for genetics. There's been an international project to try and type the entire genome within certain people from different populations, and this information is freely available. So with the result that that there has been an exponential increase really in research towards that, and I'm not really going to discuss that in too much more detail. But I think what eventually my perspective, I suppose, on the genetics of epilepsy is that I think every person with epilepsy, there is a genetic contribution to it. So for somebody who suffers a stroke and later suffers an epileptic attack, I think they are over towards the right-hand side of this graph. So it's much more likely that whatever caused the stroke or whatever the scarring process that happens afterwards is the greatest contribution to their type of epilepsy. But in some people with idiopathic generalized epilepsy, let's say juvenile myotonic epilepsy, the genetic contribution is probably much larger. One other thing I thought I might just add, just to give a flavor of the genetics, it's not even as straightforward as I say, and many people with epilepsy have epilepsy and have many of the other challenges that come with that, but sometimes people have epilepsy and may have other disabilities like a learning disability or maybe a weakness down one side, and epilepsy is just a part of the underlying process that they have. The underlying process is causing maybe a learning disability as well as epilepsy. And there can be many different causes, and a lot of our time as doctors, particularly in the initial evaluations, is trying to see, do people with epilepsy have something else going on as well? So one of these things would be, and this would be quite unusual, but we would look to see if there's any abnormalities within the brain where there are clusters of cell or nests of cells in a place where they shouldn't be. So in a very broad sense, if I want to move my left hand, a message has begun on the outside of my brain, which we call the grey matter, and then is spreading down through nerves in what we call the white matter. Sometimes if there's nests of grey matter in the white matter, where it shouldn't be, then that can understandably give rise to an epileptic focus and may cause other problems, maybe like a weakness down one side. So our fancy word for that is focal heterotopia. And this is a brain specimen of somebody with showing the pathology more clearly. And what we think is happening here is that as embryos and as a fetus, the brain forms, the grey matter is in 6 layers on the outside, and the layers start deep in the brain, and they move along scaffolding, which is other cells in the body, to the outside. But if something arrests that process on the way, they'll end up in the middle somewhere. They didn't quite make it to the edge. So suddenly now there's some grey matter within the white matter. And it so happens that we have found, or some of the genes underlying this have been found, and they can give rise to characteristic MRI findings. So on the left is a normal MRI scan. In the middle is a woman who has epilepsy, and you can you see a line in the middle on either side of the black area? So we call this a double corton, so it's like a double cortex, and that tends to be very epileptogenic, very likely to give rise to seizures. This is an X-linked condition, and I'm not going to talk too much about this and bore you with this, but X-linked conditions tend to be worse in men than women. And on the scan on the right, you can see that the brain looks smaller, first of all, and has lost the nice kind of curves that happen on the outside of a brain. So this person is more severely affected. But if we knew one member of the family had this condition, and then another member of the family was to develop epilepsy, we would be able to offer a genetic test to that second member to see if they had the condition as well. So sometimes genetics, apart from giving us an understanding and helping us to develop future treatments for epilepsy, can be of direct practical value in terms of genetic counselling for other family members. Again, I'm not going to talk too much about pharmacogenetics, but I think one of the very exciting things that family studies moving to genetics, and now genetics moving towards pharmacogenetics, is giving rise to, I suppose, great excitement. And that is the hope. I think when a person with epilepsy comes to the clinic, we know that certain anti-epileptic medications are good for certain types of epilepsies. And we know of the side effect profile for medications, and that can be explained to people, and the risks explained of contracting or of whether they will develop side effects. But really, we don't know, as a doctor, I don't know if this person is going to get a side effect or not, and I can't say the likelihood of them getting the side effect. Well, we can give some idea, but really not a very good idea, not as good as you would want or I would want. And the hope with genetics is that we may have a blood test, And this is very fanciful because I think this is a long time away. And Dr. Cavalieri may give out to me afterwards for being so hopeful. But the hope is that with time we would be able to do some blood tests that would be able to offer a percentage prediction of how likely an anti-epileptic drug is to be successful in reducing seizure burden or maybe causing seizure freedom, and how likely it is to cause certain side effects, or to what dosage we should bring that patient to. Because again, these are very much based on, patient starts off, we have criteria, we have certain recommendations for how medication should be given. But again, it's the same medication may have a different side effect profile on somebody, on one person as opposed to another. So wouldn't it be lovely if we understood the genetic background to this? Now, it turns out that this is very complex, and it's understandably, if we stood back for a second to realize what's actually going on with taking a drug, intuitively you know it's going to be very complex because of all the different things that happen. So a person takes a medication, it's absorbed, but it's absorbed to a different extent in different people depending on their gut and some genetic differences within their gut. It's in the blood. Sometimes it comes from the blood into fat, and again that will depend on what people's fat distribution is like. Then it has to cross the blood-brain barrier. There's proteins that sometimes bring some of the anti-epileptic drugs across the blood-brain barrier, so that makes it, and again there's genetic differences underlying the protein frequency and the protein structure bringing that medication across. The drug acts on different targets. Everybody's brain is different. We all have different targets. If you think back to the gates, we all have slight differences in the gate structure along the neurons. The drug then has to be cleared from the body. It has to be cleared by the liver. Oftentimes there's multiple enzymes in the liver which are clearing it. We all have different livers. And then has to be cleared by excreted out through the kidneys. And again, our kidney function may be different from the next person. So it's very complex in trying to give a total picture of, in trying to say, well, this is the chance that this medication will work, and this is the chance that you're going to have these side effects. So it is a very challenging area, and I don't want you to go away thinking that genetics is the answer to everything, although I used to believe that. But I think still a lot of good work can be done. So just by way of recap, one of the important things I wanted to bring out in my talk today was, I think, this ripple effect of a person who's newly diagnosed with epilepsy and the immediate impact that has on the family, and how that person with epilepsy and that family then interact with the community and society then at large. We've talked about the specific areas that I think this affects, so namely cognitive, psychological, social, and stigma. We've talked about the genetics of epilepsy. I think we realize now that not all clustering of epilepsy within a family necessarily has a genetic basis, and not all people who have a genetic cause or a profound genetic cause for their epilepsy are likely to pass that on to their children. But the one thing common to improving all of these things is education. It's a bit like Tony Blair's pre-election manifesto in 1997, where he was asked what is his three main policies. He said education, education, education. I hope with epilepsy we're more successful in carrying out that policy than he ended up being, but I think education comes from educating each other, educating the doctors, educating the nurses, and particularly in fora like these, where we have Brainwave, which interacts with all those different subsets that we've looked at in terms of society, family, community, and self. And also education, by that I mean research, research into the underlying genetics of epilepsy. And I think it's only through education that epilepsy, that our management of people with epilepsy and of their link to their family is going to improve. So I want to thank you very much for your attention, and I welcome any questions.
I'll just ask them for questions. I'll go to them at the end. Thank you, Dr. Lynch. We have a few minutes for some questions, and as per usual with these events, if you stick your hand up in the air if you have a question, I'll get to you with the mic so everybody hears the question, and then Dr. Lynch hopefully will be able to answer. First question.
I got some epilepsy there a few years ago. At the same time around, I had sleep deprivation. Is it a cause? Like in the night, my leg might jump. Could it wake me, you know? And is it part of epilepsy?
So I think there's probably two things to that. I think we call that leg jumping just myotonic jerks. And oftentimes when we're just falling asleep and our leg gives a jerk or we get a jolt, then that's a normal jerk. Now, if you're sleep deprived and so you're waking and then you're falling asleep again, then you may have a lot more of those jerks just by the nature of the fact that you're falling asleep more often. You're not just falling asleep once, it's happening to you a few times at night. So they may not necessarily be epileptic jerks. But your first thing you said about sleep deprivation is absolutely true. And in general advice that I suppose I can speak collectively as epileptologists, would give to people is that sleep deprivation definitely is a risk factor for a seizure. But some epileptic syndromes are more prone to that than others. And by that I mean people with juvenile myoclonic epilepsy is much more susceptible to having a reaction to lack of sleep than others. But as a general piece of advice, good sleep pattern is very important, but it can be very difficult to distinguish if people are having epileptic seizures at night, and so I wouldn't say necessarily that they are epileptic seizures. It could be a side effect of tablets, but that would be an unusual side effect of tablets. Any anti-epileptic drug has the potential to paradoxically worsen seizure control, and thankfully that happens very rarely, but that can happen with certain medications, and that would have to be, but usually that's quite clear. There's been usually a very strong temporal relationship. There's been a clear link between the onset or the starting of a medication and a worsening of seizure control, which persists. So I would think it's unlikely it's related to medication, but it is possible.
Sorry. Hi.
Hello.
You were saying that there is an most likely oligogenic basis for epilepsy syndromes. With there being myriad oligogenic syndromes, there's then most likely going to be a huge combination of genes involved in this. Do you think you're going to find a pattern of set genes involved in this, or do you think it's going to be just a lot of is it going to be a huge, vast, there's going to be a vast array of genes involved?
I think that's the million-dollar question, and that is the question that major funding agencies are also asking. They're asking, what is the utility of putting thousands, sometimes hundreds of thousands of pounds into very large population studies? What is the likelihood of success? And I don't know the answer to that. And my opinion in relation to that has changed a little bit over the years, in that I think we are less likely to have a comprehensive overview of the genetic contribution to epilepsy for each individual who comes to the clinic. I think we will get a greater understanding, but I suppose my initial hope would have been that that a patient would eventually come in and we'd be able to say, well, this thing happened to your brain, and this is your genetic makeup, this is the pattern we're looking at, this is likely how you're going to get on, this is if you're likely to get on well with these medications or not. I would be a little more pessimistic about that at the moment. So I think, to answer your question directly, I think it's unlikely, but I think we will get a lot more information, but not as much as we want.
Hello, how are you? I have an 8-year-old daughter with double cortex syndrome, and I've never actually heard anyone mention it before, so I'm relieved that someone else knows about it. My question is relating to memory and concentration. She's currently seizure-free. She also has a learning disability, but I'm just wondering how to improve really her memory and concentration. Is it directly related to the learning disability or the drugs? We're just trying to find an education program that will suit her best, really.
Yeah. And oftentimes, the double corten can be a difficult epilepsy to control. So that is fantastic that she is seizure-free. But it is oftentimes associated, because that would be considered a fairly major problem with the brain, then it is nearly always associated with a learning disability. And so that's a baseline. There's nothing we can do about that. But you're absolutely right. Certain anti-epileptic drugs can have cognitive side effects, that they make people drowsy, make it very difficult for them to concentrate. And I think that the whole thing is trying to get the balance right between the dose and the medication. And oftentimes it's the mother who knows best in those situations. They know of the little changes that's happening. You know, particularly I think with people with learning disability sometimes cannot, I suppose, speak as well for themselves as they would like to say exactly what's going on. But again, a family member, like the mother or like the father, or sometimes a brother or sister, knows exactly if they're right or wrong, or overall if the pattern of things has gone well with a new anti-epileptic medication. And your second thing about, I think if people have a lot of seizures, then that can affect their concentration. So at least that's been, we can put that to the side with your daughter, but it now comes back to medications. But again, I think it would be unlikely that she's ever going to be as good as you would like her to be if she didn't have the double cortin mutation. But again, we would never, or at least people should never stop trying to make sure we've got the medications probably at the lowest we can get away with for people who've been seizure-free. That's still really important. Yeah, because actually, as a general rule, people with learning disability are more susceptible to the side effects of anti-epileptic drugs, more susceptible to having a decrease in their cognition. So I think, as doctors, the onus is on us to be even more careful about and changing their anti-epileptic drugs accordingly. Yeah.
There's two final questions, lady here and a lady towards the back.
Hi, yeah. I just wanted to ask, my son is 3.5, and he was diagnosed recently with epilepsy. He had tonic-clonic seizures, and they're controlled with Epilim. And I'm just wondering about the myoclonic jerks. He has them, and what effect that would have on his brain or his concentration.
I think as a general rule, we're not too worried about myoclonic jerks causing longer-term damage. They do indicate that there is seizure activity going on. So I suppose somebody who's having a lot of myoclonic jerks definitely has quite an active epilepsy. But we don't think that they are causing problems the way generalized tonic-clonic seizures would be having a much more profound effect on the brain. So myoclonic jerks as a thing wouldn't be too worrying, but overall they are indicating that maybe we might need to be more aggressive with the anti-epileptic medication. But again, it comes back to what we were just saying about trying to get the balance right and not making your son toxic on valproate.
Should the levels be increased, his Epilim levels increased to get rid of them altogether, or is it worth taking that much medication?
I think the important thing is, I suppose, is to have a perspective on how he's doing overall, so as to know what are the other seizure types he's having. So if he was having generalized tonic-clonic seizures, or was he having staring attacks that we might call absent seizures? Yeah. And I think the goal would be to try and, in the first instance, to try and make him seizure-free from the generalized tonic-clonic seizures. I think it may be less important to control the myoclonic jerks, because we don't want him to become toxic on the valproate. And that's a tricky thing, and it's not something, I would even decide over 2 minutes in a clinic. It would be in discussion with you, and there'd probably be phone calls to the epilepsy nurse specialist afterwards to saying, what little change this has made, has it been good in terms of his overall thinking and stuff. So there isn't an easy answer, and there is a trial and error approach to it as well, which is sometimes unpalatable for parents to have to deal with, yeah.
Okay, the other question was similar, so we're moving the last one to here.
My question is, why do they use 2 types of medication?
Yeah.
Because my honest opinion is that one should be.
Yeah. So you're right, and I think that the general principle of treating a patient with epilepsy with their anti-epileptic medications is to try and give the lowest dose and the fewest anti-epileptic drugs possible. So we try and just have one medication to treat the epilepsy. But we also know that only about 70% of people will be seizure-free on their medications. And because epilepsy can have devastating effects, or at least epileptic seizures can have devastating effects with people having injuries, fractures to their arms or their legs in the seizures, we may be more aggressive in talking to the patient and trying to treat it. And oftentimes the addition of a second or even a third anti-epileptic drug reduces down the seizure frequency. But you're right in thinking that it's unlikely that the addition of a second or third will make them seizure-free, but it may reduce down their seizure frequency, and the balance may be more in favour of them having less seizures and less injuries, and they can still tolerate the second anti-epileptic drug almost or as well as when they were on one anti-epileptic drug. Yeah.
Her liver is badly damaged.
Yeah. And that's tricky, you know. I think the question is, she said her daughter was on Tegretol and then was put on Epilim as well. And both of those drugs are cleared through the liver, so they will always have an effect on the liver. It can be difficult to tell. I think I'm going to sound like I'm trying to squirm out of this question, so I have to say, first of all, you know, there's many reasons why somebody's liver could be affected, and sometimes we focus just on the anti-epileptic drugs and think that's it, and that can be a mistake. There can be other things going on. And certain anti-epileptic drugs do work poorly in combination together, or are more likely to give side effects. It's very difficult for me to comment on an individual thing like that, yeah, but it's something we would be very aware of, and our general principle would be, I agree with yours, would be to give the least amount of medication that we can get away with. Yeah.
Could I ask you to put your hands together again, please, for Dr. Lynch? Thank you very much.